So thank you so much for joining us today. I'm Jennifer Fish. I'm your host and webinar moderator. This is the third of a series of implementation science and EMS webinars sponsored by the Pre-Hospital Guidelines Consortium. The focus of this one is designing EMS evidence-based guidelines for dissemination. And I'm really excited. We have two content experts here today that are going to provide a really interesting overview and discussion of this topic. So I'll introduce them. I'll outline the guidelines for obtaining CME and CAPC credit, so continuing medical education, and then paramedic credit. I have some instructions on that in the chat, but we'll go over that in more detail as well. And then we'll turn it over to our two speakers today to give an overview of their areas of expertise, and then we'll have a facilitated discussion about the topic of designing evidence-based guidelines for dissemination in the very unique EMS environment, and plenty of time for open audience Q&A. If you wish to obtain continuing medical education or CAPC credit, please enter your name, email, and either AMA or CAPC in the chat. And then I will be in touch with you post this meeting with more information on how you can attain 1 hour credit for today's webinar. All right, so it is my pleasure to introduce our two speakers today. We have Dr. Ross Brownson, PhD. He is the Lipstein Distinguished Professor of Public Health at Washington University in St. Louis. He directs the Prevention Research Center at Washington University and studies the translation of evidence to public health practice and policy, focusing on environmental and policy determinants of chronic diseases. Dr. Brownson has published over 650 peer-reviewed articles in 16 books, including the first comprehensive text on dissemination and implementation research and evidence-based public health. He's received numerous awards for his work in research, public health practice, and mentoring. Our other speaker is Dr. Daniel Patterson, PhD. He is an associate professor of emergency medicine at the University of Pittsburgh. He investigates threats to the health and safety of our EMS clinicians and first responders. He's led dozens of studies using observational and experimental study designs, including laboratory-based trials where he deprives participants of sleep. In addition, he's completed over a dozen systematic reviews and created the first evidence-based guideline focused on fatigue risk management in high-risk operations, which will be the subject of much of our discussion today. Finally, he works regularly as a paramedic in the community and serves as deputy editor of the Pre-Hospital Emergency Care Journal. So thank you both for your time in preparing for this talk and your time today and sharing your expertise with us and our audience. So I'm going to turn it over to Dr. Brownson, and he's going to be educating us all on what exactly is designing for dissemination. Dr. Brownson?
Yeah, thanks. Thanks, Jen. And thanks everyone for joining today. Couple bits. I'm a public health person, as Jen said. I have little expertise in emergency medicine, but I think a lot of these lessons we've learned in public health and other areas of medicine will apply here. I hope so. So this one is the two main things I'm going to cover in just a very short overview of this topic. Some of the core principles, how we're doing, a little bit about areas we might do better in, and then a little bit about some resources. And this D4D, as I'm sure you figured out by now, is the shorthand we'll use for the term designing for dissemination. And in this world of implementation science and dissemination research, I think this cartoon summarizes it all well. The latest research shows that we really should do something with all this research. And that's what guidelines try to do, really. And so that's what we're going to be focusing on today. So next slide, please. Okay, so I'm going to give you a little bit of the backdrop. This will make your head hurt a little bit, but the only operational part of this is from an article in the Annals of Internal Emergency Medicine, is that any problem we're trying to address is a complex multi-level problem. Like if we're getting better emergency care, it's going to happen across these levels. This is a 4-level ecologic framework. It includes individual, organizational, community, and policy levers, if you will, with some examples within each one. And so I won't spend much time on this in terms of all the details. This article is a nice read if you're interested. But the main point is here, it's a complex world, and the most effective practices that we do address multiple levels of this ecologic framework. Next, please. And those of you in the implementation science world will know this book called Diffusion of Innovation. It was first published by Ev Rogers in 1962, believe it or not. And Ev grew up on a farm in Iowa, I believe, and he was sort of got intrigued with how farming practices do or don't spread, and led him to write this book called Diffusion of Innovations. The origins of this go back to the early 1900s to a French judge who observed people coming in his courtroom and started keeping track of those, and thought of some of these principles of an S-shaped curve where you get these early adopters, you get a whole bunch in the middle, and then you get some on the other end. Sometimes we call the laggards, who are the late adopters. Mostly what you want to do in terms of guidelines like EMS guidelines is try to work on that middle group. And the middle group, I highlighted two parts of diffusion. One is the innovation, and the innovation here is a guideline, an EMS guideline. It has to have some advantage over existing practices. It has to be compatible with the workflow and the culture of an organization. It can't be too complex. If it is complex, it has to be explained and taken through multiple steps. It has to be able to be trialed out, like a pilot work before it leads to a larger scale. And then the last one there in the upper left hand, we have to be able to observe effects and document those and feed those back to the users. And then the other one is on the bottom, and we'll hit on this in some of the discussion later. Change agents are very important. A lot of you are these change agents, opinion leaders who help things spread better and more quickly. You know, kind of the famous quote in implementation science that it takes 17 years for 14% of original research to reach practice. And that's way too long, and we need to speed that up, and that's some of the discussion we'll have today. Okay, next slide, Jen. All right, a little bit of the backdrop of what we know. First, starting with the definition. Not rocket science, but what we're trying to look at with the idea of D4D is looking at a better fit between the methods, the research, and the context where it's being adopted. So in other words, starting early, planning early, and meeting the needs of the audience. And so what are the key aspects? Well, it's centered on the audience. It's not centered on the researcher. It has to be accessible in terms of language and the activities we're asking an adopter to do or think about doing. It needs to have partners and stakeholders engaged in the process. You'll hear more about that with Daniel's presentation. And then it's going to occur across all different phases of a project. And so that's important to keep in mind as we go through. And I'm going to show you a little bit more about D4D. This is from the public health world. I've got some other clinical slides as well. All we're showing in this is the column for researchers. Ask researchers, how do you best disseminate your research to non-research audiences? Okay. The second column are local practitioners, public health and primary care. And the far right column are state level practitioners. And what do you see? You see a real mismatch there where academic journals are the top one by a large margin over everything else. The one for local practitioners are seminars and workshops. The same for state practitioners. So you see very different rankings there. And then I picked the second most common, academic conferences. Most practitioners don't attend many academic conferences. The second for local practitioners are professional associations. And the second most common for state practitioners are journals. And so you see there a real mismatch and sort of the rationale for what we would like to be doing better. Okay, so next we're going to talk about a little bit more about what we know or sometimes we don't know about D4D. Okay, next slide. When we ask people in the research world, and this one is from a mixture of clinicians, mostly working in primary care and some public health practice. The obligation here was just a question is it an obligation for researchers to disseminate their research to non-research audiences? And you can see, I mean, think about this. Where do researchers ever agree? If you combine strongly agree and agree, that's what is that, 88%. Think about how often researchers ever agree on anything at 88%. So there's a strong sense that I take this as we need to do better. We need to do better at this. Maybe we're not great at it, but we ought to have an obligation of doing this. And in the case of today, we need to do better with guideline dissemination. Okay, next slide, Jen. This is a take on the methods that people use on the left-hand column. So if people are trying to reach different stakeholders, the people who would do the implementation of a guideline, across the left-hand side is a set of methods that people use during the research project process to reach these people. Focus groups, advisory committees, user panels, team members, having the audience as team members, having people help in interpreting the data, and having people help in disseminating. And so this study was done with both clinical and community level workers, and we had a sample for both the United States and Canada. And the red parts are things that I think are important to seek out. The advisory committees are used more often in clinical settings, and enlisting people as team members look like they're used more often in community-based research. On the right-hand side, I think it's interesting that we can learn from Canadians that almost across the board here, they do better. In fact, in every category, they do better than those in the US with identical questions. There's probably a lot of reasons underlying that. We can talk about some of those in discussion if you want. Probably a bottom line is that Canadian researchers are incentivized in different ways to do a better job with these D4D issues. Okay, next slide. And then very briefly, we asked this in a different way in this study. We also asked it about, for researchers, what will have the biggest impact on your career? And what do you think will have the biggest impact on practice and policy? And it's a little different than some of the earlier data I showed you. Academic journals, of course, publish or perish, but people realize that probably has a pretty small impact on practice. The areas they thought had the biggest impact was the area of face-to-face meetings with stakeholders, with adopters, and zero, that's kind of sad, but 0% impact on one's career. So how do we line up things like promotion tenure guidelines or incentives for researchers so that we can focus a little bit more on the right-hand side? If we focus more on the right-hand side, taken with the methods that I talked about in the last slide, we're probably going to see bigger uptake of evidence-based guidelines. Next slide, please. Okay, one slide, I think I just have one slide from the practitioner perspective. So remember what I just showed you was from the perspective of researchers, both clinical researchers and community-based researchers. This is another study that a postdoc of ours, Tembi Shato, led, where we asked a lot of the same questions to large samples of clinical practitioners, mostly in primary care, and then public health practitioners. And a couple things I highlighted here that I think are important. Reading academic journals is more common for clinical practitioners than it is for public health practitioners. Email announcements, learning through email, which is usually from a professional organization or often from CDC, is more common for public health practitioners than for clinical practitioners. On the lower group, who do they trust? The highest trust for clinical practitioners is national governmental agencies. I'm sorry, the highest trust is professional associations. So the American Medical Association or the OBGYNs or emergency medicine societies. The biggest trust for public health practitioners is governmental agencies. Mostly that would be CDC. So there's differences whether you're talking to a clinical audience or public health audience. For things to happen, you want to know where they get the information. You also want to know who they trust. Okay, next slide. All right, I'm going to end up with just a few resources for you, really featuring one resource. And this is something our team here has developed. It's Mara Kepper is the lead on it. And we'll have some resources later that you can use. The web tool is basically, it's designed to help increase the uptake of an evidence-based practice. This can easily be used with a guideline. And so it defines some things. It looks at what a product might be from research. The tool is primarily developed for researchers, but for people who are the adopters, it also can be very useful. Okay, next slide. The two parts of this, if you look on the kind of upper left-hand side, the orange is the educational hub. So if you want to just learn more about D4DS, so one thing I'll note, in this one we added sustainability, so designing for dissemination and sustainability, which is kind of the longer term adoption of a practice. In other words, if someone initially adopts a guideline, what helps them keeping and sustaining that guideline over time? So if you want to do kind of the light version, you do the educational hub. And then on the next slide, if you want to do the longer version, you would do the overall action planner. And basically this takes you from a whole set of steps that moves you through the process so that you're able, and what happens when you use this is you enter it as if you're a user. And the user fills in a very short registration and then usually starts with the educational hub. And then it takes you through a whole series of processes, which is basically that wheel. And the wheel helps you in the terms of like developing a process, working it through, it goes around to evaluation and takes you in a deeper dive in each one of those parts of the wheel. So if you're interested in that, it's a free tool. It's available online, and we would welcome that. We also have a team that can help you in learning more about this. All right, next. And so that's it for the first part. I know we've got time for Q&A later, and I'm going to hand it off to Daniel.
Thanks a lot. It was a great presentation, and thanks everyone for the opportunity. Next slide, please, Jen. Okay, so the origins of the fatigue guideline, which came out and was published in 2018, actually goes way back to 2013 when the National EMS Advisory Council put out an advisory that basically said, hey, NHTSA and other government officials, do what you can to help identify the best available evidence and disseminate that out to the EMS community so that fatigue can be addressed at the local level. Next slide. So what happened was in 2016, NHTSA funded a partnership between the University of Pittsburgh, National Association of State EMS Officials, and NHTSA. And in that partnership began a multi-year project that resulted in several outcomes and several products. The first focus area or the first product was to go out there and identify the best available evidence, synthesize that into an evidence-based guideline for addressing fatigue, specifically in the EMS and first response setting, and then test one of the recommendations in a trial and see if there was any effect based off of that data, and then also provide an online free resource for personnel, whether that be some scheduling tools informed by the best available evidence or some other resource. And what I'm going to talk about is the first part, which is the evidence-based guideline work. This was, as some of you who are on the call or webinar know, it was a very laborious process. I pretty much spent my entire effort for multiple years just on this project, along with 24 other investigators and staff, including Dr. Martin Gill, who's on the line, and some others. We reviewed over 40,000 pieces of literature, and yes, lost a lot of sleep in the process of doing this, ironically. And we're able to engage with experts in evidence-based guideline development. We discovered early on that other high-risk industries, such as aviation, rail, nuclear power, those who we have high respect for in terms of their development and approach to dealing with fatigue and their regulations, their their processes, their tools and resources that they have available to address this issue of sleep and fatigue. We respect them very much. But surprise, surprise, none of those industries, none of them have ever developed an evidence-based guideline to address fatigue in the workplace. That was number one, our biggest surprise. So we were the first, hooray for EMS, hooray for first responders, in that we were the first to anything, right? So in 2018, we were able to publish our work, which was informed by 7 PICO questions. So we sought to identify the best available evidence for 7 questions. We found adequate evidence to produce 5 specific recommendations. And that, again, was published in 2018. Next slide, please. Here are the 5 recommendations. And if you know anything about the EBG process, you know that this was a very long, very detailed process, involved dozens of individuals. First recommendation, and a lot of these are very pragmatic, right? Number 1, go about, if you're in leadership, and these are geared towards and targeting leadership, okay? Go about addressing fatigue and sleep in the workplace by trying to assess it using reliable and valid instruments to help monitor it on a regular basis. Whether that's every quarter, after every shift, that's totally up to you. But try to use some reliable and valid instruments to help you assess the issues in your organization. Number 2, try, when feasible, and again, this is not strict recommendation, when feasible, limit shifts to 24 hours or less. There's plenty of evidence out there that shows when you try to go without sleep for 24 or more hours, you're just not at your best. So the evidence informed that. Again, this is with a caveat that a lot of organizations, rural, frontier, other types of organizations that have other strategies in place, may not need to abide by this or to adopt this because they have other strategies in place. But in general, if you don't have other strategies in place, try to limit shifts to 24 hours or less. Next recommendation was to provide access to caffeine. Notice it is to provide access to caffeine, not that you force caffeine down your clinicians' throats, because there's plenty of evidence out there that shows that this is when used appropriately, a safe and regularly used stimulant that can help to mitigate fatigue during long duration shifts in particular. And also give your crews the opportunity to nap on duty, especially during night shifts and long duration shifts. Plenty of good evidence there to support that recommendation. And then obviously education and training. We do not, in the EMS education world, do a very detailed job of giving our crew members a dose of reality that when you go out there into the world, you will be deprived of sleep because of the way that EMS is structured and deployed. So prepare them in their formative education and also with regular continuing education. Next slide. In addition to just the recommendations, which you heard earlier, often get published in peer-reviewed journals and other documents that public health officials or frontline personnel have limited exposure to or rarely ever read, we produced a guidebook, which is a synthesized version, sort of a Cliff Notes version of the recommendations, and included in that guidebook were sample policies, because oftentimes, it's hard to operationalize a recommendation, for example, into anything tangible. We took the extra step to provide a template of policies that individuals, or SOPs, that individual leaders, supervisors, directors, administrators could use and to tailor that to their own needs that incorporated these recommendations. And we obviously realized that there's no one size fits all because we are all very familiar with EMS being quite diverse. And again, this is available. It's freely available on multiple outlets, in particular the emsfatigue.org website. Next slide. Now, what we discovered is, years after this was published, these recommendations were published in 2018, we did a study to investigate the effect of education and training. And it was a randomized waitlist control trial, cluster randomized. So a group of EMS agencies got early access to the educational materials, which were online. and the other agencies, which were randomized to the waitlist group, got them a little bit later. And individuals in the organization who enrolled could have unlimited access to these educational materials, which we developed based off of the best available evidence. These were 10 modules, 10 very brief modules, are about 10 to 15 minutes long each. And they addressed everything from talking about what is and what is not fatigue, chronic fatigue versus sleepiness. What is adequate sleep? What does sleep health mean? What are some sleep disorders? How do you get diagnosed for those? And some strategies that you could use as an individual to help mitigate your fatigue symptoms. And what we learned in this process, when we enrolled organizations into this study, is that years after the recommendations were published, because this study took place essentially right at the brink of COVID, so 2021, 2021, we were obviously dealing with that. But just several years after the publication of these recommendations, 2/3 of EMS organizations said they had no formal fatigue risk management program. Many said that they do quote unquote something, which may or may not have been informed by the recommendations. And oftentimes the response was, I'm not sure if it was informed by the recommendations, may have been. But what this data shows us is that even though we spent some time doing webinars, we did presentations at conferences after the publication in 2018, even during the process of trying to get it published, there was still less than optimal uptake of the recommendations into a formal fatigue program. And next slide. And what I want to point out here is that we are doing follow-up research to this, trying to identify some of the challenges and barriers to EMS organizations over the previous, 5 to 7 years since the publication of that work. What are some of the common barriers to adopting the recommendations, which are essentially a synthesis of the best available evidence on this topic, related to a subset of questions, obviously, not every question possible, but a subset of questions. And what we're learning and what we hope to publish pretty soon from this work is that there are numerous barriers. Number one, awareness. Awareness is very poor. So in terms of dissemination for future projects, and even for projects that may have not had follow-up work performed, awareness is obviously something to really, really focus on. And then we'll, obviously talk about some of the other barriers, I think, during Q&A, but I think awareness is number one that we discovered that very few frontline personnel, very few administrators really know much in terms of detail about what came out of that EBG back when it was published in 2018. Okay, Jen?
Thank you so much. So we'll start our discussion portion of this. For those in the audience, please feel free to start putting your your Q&As in the chat. You also are free to raise your hand on Zoom and ask verbally questions when we get to the open audience Q&A part. But if you prefer to chat it, please start dropping those in the chat right now. So I'm first going to go to Dr. Bronson and talk about if you have any specific EBG examples or other healthcare disciplines, and it sounds like public health practitioners, state departments of health, maybe one of those that you feel are most applicable to our EMS environment, and what can we learn from those other areas and organizations so that we don't reinvent the wheel. And so we're particularly interested in any success stories you may have or you may have heard of, or any pitfalls that you think are applicable to EMS.
Yeah, that's a great question. And I'm glad you framed the success stories, because there's probably more needs of improvement than there are successes, but I'll give you a couple of examples, one that sort of bridges clinical practice and public health practice, and one that really is focused on clinical practice. One example, a lot of you probably have heard of the DPP, the Diabetes Prevention Program. Started as a clinical trial. It looked at the difference between metformin as prevention versus physical activity and healthy eating delivered in a clinical setting, was successful, showed the value of behavioral counseling on par with metformin. And that led into a number of public health guidelines, mostly administered by the CDC, but other organizations as well. And over the years has led to massive uptake through non-health agent, like the YMCA, for example, has done a lot of replication of the DPP in more of a community-based version. And so that's a great example of something that sort of bridges clinical practice with public health practice. I think another one I thought about was with surgical checklists. I think some of the definitive work on that was published like 15, 20 years ago. And basically, so a simple checklist can be effective in reducing complications, even reducing mortality in bigger studies. And so that's an important one as well. I think the common lessons from actually Daniel's talk hit on a number of these really well. The lessons could be capacity is different in every agency and every practice, so you have to address that. You need to talk not only about the guideline, but the implementation of the guideline. And a clinical overload is obviously one that affects every different kind of guideline that comes along. And then trying to learn about what turnover in an organization means. What we see a lot in high uptake of guidelines is there's one or more opinion leaders that really are leading that. Well, what if that person leaves? And what if the practice is left with a whole different group? And we've got data from another study in tobacco control where in some of these state efforts, one person was the centerpiece of what was happening. So I think and the pitfalls of these would basically be the flip of not having capacity or not having the opinion leaders or not taking care of implementation and implementation guidelines. I think the other important part is pitfalls. There aren't incentives. There's not an adequate level of organizational support for implementing the guideline as well. The problem usually isn't the development of the guideline, just like Daniel hit on. It's usually the dissemination and uptake of the guideline. So there's a few thoughts for you, Jen, on that question.
Yeah, definitely. I wanted to underscore, you mentioned checklists. So checklists, I think, are very applicable to EMS, definitely used in some EMS agencies, notably for handoffs, because a lot of important information can get lost in the handoff between EMS and the ED receiving team. And then as I study pediatric EMS care, there's a newer initiative to have a pediatric emergency care champion embedded within each EMS agency. But you mentioned something that gave me pause thinking about that, which is what if that person leaves and they're your pediatric liaison and in charge of all your pediatric education, and if all the eggs are in that one person's basket and they decide to move on to something else, then that can be very difficult. So yes, great examples. And then I wanted to dive a little bit more into something you touched on in your talk, which is the difference in dissemination methods between those used by us traditional academic types versus what's really needed or wanting to be received by the actual practitioners themselves. And so I was curious if you had any positive examples or lessons learned getting things out through email, social media, trade organizations that did enhance the dissemination of an evidence-based guideline.
Yeah, no, it's a great question. And I sort of alluded to this in the slides, but researchers are usually very good at disseminating to other researchers, and they're usually not that great at disseminating to other audiences. So start with recognizing of the skill set we have or don't have. And so who on your team will have a better skill set for that in the researcher, and helping the practice world, have the practice world help us in identifying that. This sort of is a little bit different than how we usually think of this, but I like to try to think about dissemination like a marketer of a product would think of it. So what does a marketer do? They think of the source of the message. They think of the audience. They think about the segments of that audience and what drives their behavior. And, the incentives of an audience are very different in the research world than they are in the practice or policy world. So trying to think in that mindset of the audience and the segments of that audience, what about this is something they'd want to do and why would they want to do it? What makes it usable to them? And I think Daniel was alluding to that in a number of his points.
Oh, I think you might have frozen, Dr. Brownson.
Dan, sorry, I just got dropped. I don't know what happened.
Yeah, no, it's okay. You're back. You're back. I don't know if I froze or you froze or we all froze, but
Okay. Where was
I,
I?
I
Where am I?
see I see movement now.
Okay, good.
Okay. So I might pick us up because there's something I wanted to dive into that you mentioned, which is that incentive. And you had talked about when you were discussing Rogers' theory, the relative advantage. And this is something I've seen pop up, and we can talk about this with regards to fatigue when we switch over to Daniel in just a minute. But um, a lot of times some guidelines come out and it's almost like what you would call a substitution with, or a replacement type of situation. Use this
Yeah.
medicine, not that medicine. We used to think A was great, but now we think B is greater. And from the EMS clinician perspective, it's kind of like, well, I spent 10 years doing A and now you're telling me to do B. What is the relative advantage here? And so I was wondering if you could talk a little bit more about your experience with that or your knowledge and how maybe EMS can work that into the development and publication process of our EBGs.
Yeah. Well, so we do these things. We do a technique called concept mapping, and we ask people to look at a rating for impact of a practice versus the feasibility of a practice. And of course, where you want to start is the things that have big impact that are more feasible. And I think the feasibility issue gets to some of the things you were asking about, Jen. Now, there are things that are very impactful that might take more effort to do and might involve some substitution. Like if a new practice appears, there's a limited amount of clinical time that can be had. And so how do we trade some of those things off? I think there also needs to be like a commitment to lifelong learning and innovation in an organization so that, I talk about this a lot in public health. There's a real inertia effect in public health. We do it this way because this is how we've always done it. And sometimes we need to reinvent that and look at the latest science to do that. So I think it's a real challenge. I think those properties that Ev Rogers came up with, that the upper left-hand part of that slide, are super important in just about any innovation that we're trying to diffuse and increase uptake of.
Great, thank you. All right, well, we're going to move to some pre-submitted questions for Dr. Patterson, and then we'll open it up for the audience. So you touched on this, but I wanted to get more information on what surprised you the most with regards to the dissemination and uptake of the fatigue and EMS guidelines. Things that you had in the back of your mind along during the process, like, oh, this might be a roadblock, and then maybe some other things that you hadn't considered that were surprising. And then, you mentioned 2/3 of agencies didn't have any formal fatigue risk management program, but if there are any agencies you know of who are positive models of dissemination and adoption, I always like to highlight that. So I wanted to get your thoughts on those things.
Yeah, so I don't think it was necessarily a surprise because we knew during the guideline and recommendation development that any discussion of shift duration was a hot topic, hot button issue. And we actually spent a lot of time in the development of the recommendation with all the experts in the room and folks trying to craft the language appropriately in response to what the evidence said, going through that grade process of considering the risk and benefits, all those elements of what do you consider when wording a recommendation. So we knew that it was a very contentious issue, and the evidence was staring us in the face, right? And the reaction from some out there was really, forceful. That, once they latched on to the shift duration issue, consideration of everything else was not in their view. They wanted to just basically latch onto that, and that was it. So I think the biggest surprise here is that is when approaching an element of operations, because again, EBGs for most in the room are geared more towards clinical issues. This is a very unique one because it's an operational area of focus. But when dealing with a potential recommendation that may be considered hot button or controversial, I guess go back and really consider, are you willing to put yourself out there and the work that you've done and the group and everyone who's done to deal with that response? Because I do think it sort of cause a little bit of a challenge in dissemination and uptake. Because once a leader or once a group of individuals latches on to one aspect of the EBG that they feel is not compatible, or the interpretation of what the recommendation says is not what was meant by the way it was worded or the background information, that can be a very big barrier to overcome. So I think we spent a lot of time trying to explain in a caveat kind of way. The caveat here is, except in these kind of situations, the essence of that one recommendation. Everyone agrees that fatigue is a problem in the EMS occupation and the EMS systems, but actually doing anything about it is a really big hurdle to jump. In particular for many organizations, because they are at, just the edge of having to call mutual aid or needing additional personnel at a moment's notice. And I actually work and have worked in organizations where that happens on a daily basis. So when you're dealing with operational challenges, the application and uptake of some of these recommendations may be difficult, for organizations to adopt. So that was not necessarily a surprise, but something that really lasted quite a long time. And then we had COVID.
Yeah.
And with COVID, it was almost like all bets are off. We need everyone, all hands on deck. Forget about fatigue. We just need people to help.
Mhm.
And you can't blame any of the administrators or directors or the frontline personnel for staying longer, for helping out as long as they can, or for basically staying awake for long periods of time because they need people to be available. You can't blame them for that because we were dealing with a international emergency. So that really, I think, torpedoed a lot of any kind of momentum we could have had with individuals and organizations adopting, a lot of these recommendations. But yeah, and so positive models, though, we actually did have a number of organizations reach out to us, and me in particular, who said, we've adopted all these recommendations. We have a program. We've done everything that was recommended. Here's how we do it. So we actually did have some great examples of success, but obviously far fewer than we would have liked.
Yeah, I think you touched on something that may distinguish EMS from some other fields, which is that we not only have clinical guidelines, we have operational protocols and guidelines. And it's funny when you tell people to do something different with a patient, that's one thing. When you tell somebody to do something different with their work schedule and their life organization, that's a whole other thing. And
Right.
so in working with you on the Sleep Foundation grant, I've seen in the interviews you all did that there is this the hyper focus on this 24-hour shift duration, which is really interesting because the other it's almost like the other four things just didn't exist. The other four recommendations dissolved into the ether with this hyper focus on 24-hour shifts, which is not what you were mandating. It was
Right.
a
And
a very moderate suggestion.
right. And there obviously the way it was worded needed to be thought through more, I think, in greater detail to not come across as being an edict or thou shalt do this,
Mhm.
but if you read the recommendations in detail, it says these things, except for, when dealing with frontier, rural, or other kind of operations, and if you can incorporate these other recommendations, you're doing great things to address the problem. Not that you have to adopt these, but these are just recommendations. So trying to explain that after the fact, I think was a frustration and a big challenge. And just to be, upfront with everyone, I still work shifts. I periodically do 24s. I actually do 32s and 34s sometimes if the crews need help. So it's not that we, in the recommendations, say, thou shalt only do shifts less than 24 hours. No. The messaging came across poorly, I think. And I think we have to now go back in the next version of fatigue guidelines and try to correct that and prepare for those kinds of reactions if we have a recommendation that addresses, anything related to shift scheduling, for example.
And then my last pre-submitted question before we open it up to audience is when you were developing the guidelines, did you have specific or non-specific plans to study the dissemination and implementation in the future?
We very much wanted to, but we were strictly cut off from the project timeline from NHTSA. So we had essentially 5 years to do three major products, one being the EBG, the other one being a trial, and the third one that was led by a different group, a private organization using mathematical modeling to provide a free resource for scheduling to EMS services. So when those products were produced and we advocated that, hey, we still have a lot of work to do for dissemination, they said, you know what, sorry, we're cutting it off. We don't have enough resources, et cetera. So we very much wanted to, and going back into the application phase back in 2015, 2016, we probably should have advocated more strongly in the application and included a section in the application that was in greater detail that addressed this.
Interesting, because I was going to ask if that's a help with dissemination. Uh, all right. Well, we have many questions in the chat. So I'm actually going to skip over a real life story vignette that we were going to dissect and go straight to audience Q&A. And so we had a kickoff question from Dr. Chris Martin-Gill, which is actually, Chris, can you unmute yourself? Do you want to ask your question? It might be better than me summarizing, trying to get the spirit of your question.
Yeah, sure. One of the, so at the Pre-Hospital Guidelines Consortium, we've been doing systematic reviews of all pre-hospital guidelines. That actually leads to one of the other questions in the chat about how can any of these groups that are interested for any of these practice kind of entities, specialties, help with knowledge and dissemination of what guidelines are out there. So one of the things that we're trying to do is actually find out what guidelines are published every 2 years and aggregate those. But in evaluating those guidelines, we find that one of um, the lowest score that is achieved when you use agree to or submetric of guideline quality is for content on implementation, or in the agree to nomenclature or name for it is applicability. Uh, and we keep yearning, and our own recommendations to our EMS colleagues writing guidelines is that each guideline should include some content relevant to how that guideline should be implemented. For example, if you're going to change, this is old school AHA guideline. So if you're going to change the ratio of compression to ventilations, then think about, can AEDs be software updated at the time? Do you need to, purchase new devices? What are the barriers that are going to happen when you try to implement a new recommendation? How should people actually implement it? And so I'm curious if people know of other specialties that are better at this, maybe, or that more consistently include implementation content with the original guideline publication itself.
That would be a good question for Dr. Brownson.
Yeah, Chris. And Chris, would you say applicability, is that synonymous with external validity? Where you're thinking of that?
I'm thinking of more of implementation. So, what are the barriers and facilitators for implementation? What are specific implementation challenges that or tools that could be brought to bear in terms of putting the guideline together? And Dr. Patterson had mentioned the fatigue and EMS guideline. That guideline included its own publication that had kind of some very curse performance measures, but some comment on what are the challenges to implementing these recommendations, or what is the author group's suggestion of how to accomplish that. That was one attempt to include some of that content, and it's often missing from other guidelines.
Yeah. I mean, it's a great question. What I've observed in public health guidelines is that when you do a review, like a systematic review, many times you're stripping the context out of the intervention in order to put it together and say, here are the similarities in a body of research, and here's how you would apply it. But the context of it, like urban versus rural, or large practice versus small practice, many ways the applicability, I think the way you're describing it, is putting the context back into it. And when we think about context, we often think about that ecologic framework that I showed at the beginning. Is what are the differences at the organizational level that seem to be the levers? What are the bigger community factors? What are the values people put on the implementation of a guideline? And so I think and a lot of the Rogers characteristics fit very well with this. But I think if I was sort of boiling it down, I would think like, what are the most important contextual variables that influence implementation of a guideline? How much do they vary across different settings and populations? And what are some of the leverage points to be able to address those contextual variables? In the world of implementation science, we say everything is context, and context can be complicated. But if you boil it down to a few things that look like they drive the applicability the most, then I think that could be really important. Yeah, so there's a few thoughts anyway. Daniel, why don't you see if you've got anything to add to that?
Well, I think lessons learned from us, and Dr. Martingale on the line here has experienced those with me, is that, and we know very well how different EMS operations are across the country. Small versus large, rural versus urban, and they face very unique challenges operationally. And so we know very well that some of these recommendations are just impossible to adopt because, number one, they don't have the personnel to devote time and energy to even formulating policies or SOPs, or even training the personnel on knowledge and awareness of new policies and SOPs, because they're too busy staffing the ambulances, or helping crews out, or even trying to get the budget together, or what have you, running the fundraiser, et cetera. So the uptake of recommendations, we knew going into this was going to be very challenging for some organizations, but potentially feasible for others. And I think also some major challenges and levers. You talk about levers in public health uptake of recommendations. In EMS, we face a lot of different levers, and for some of these organizations, we've learned through our in-depth interview process funded by the American Academy of Sleep Medicine that Dr. Fish and I and Martingale are working on, and Brailsford, that there are some levers that we may never be able to positively impact. So, for example, some organizations, like I'll just say like a fire-based EMS operation in the Midwest, they have oversight from a board or a city council member who has a very strong opinion that you do not come to the fire station to see anyone sleeping on duty, right? That is a no-no, right? And because you have a lever like that may not be able to be pushed, you may never have a policy or a protocol or an SOP that deals with napping on duty, right? And in that organization until that person leaves the council, the oversight board, or what have you. And so there are many organizations that are dealing with issues like that. And so consideration of adopting a particular recommendation, it doesn't even begin, because they know right off the bat that they'll never get it passed. It's just too controversial, not not necessarily in some situations for the people who are overseeing the organization, the budget, the operations, et cetera. But sometimes the controversy is with the frontline personnel. For example, I mentioned, we talked a lot about shift duration. One of the old saying goes, don't mess with my shift schedule as a frontline personnel. This is my schedule. It fits my lifestyle. It fits my income needs, et cetera. So when you start to potentially introduce a policy or an SOP related to shift scheduling, for example, you are potentially going to create a wall between you, the administration, and your frontline personnel that you don't want to create, because you need them to be engaged, you need them to be happy, et cetera. And if you create a policy or an SOP that deals with that, it may create some conflict unnecessarily, some angst, et cetera. So there are levers, there are different levers for different recommendations here. And some of those levers just may not be able to be pushed. Some of them, the administration who's responsible for creating the SOPs and protocols may simply not want to fight that battle, right? So the levers can be quite significant, and they can be very unique across these different organizations because of how diverse EMS is.
Thanks, Dr. Patterson. We're gonna have to wrap it up in a couple minutes. I know Dr. Bronson has a hard stop at 12. Just going in the order of the chat, I do think we have a question from Richard, which deals with hopefully a situation that won't remain for too much longer in EMS, but that in EMS we have evidence-based guidelines, very systematically and rigorously developed, like fatigue in EMS, and then we have evidence-based practices where there is some paper that supports something. And those are also practices that folks want to be disseminated and implemented. And so the question centered on, sort of the difference between those two. Is it a subtle difference? Is it a not so subtle difference? And so maybe since Dr. Bronson has to hop off at 12, I might let Dr. Patterson take that one. And then Dr. Carpenter, I'm sorry, I don't know if we're going to get to your question, but I trust that you might be able to send it to Dr. Bronson offline.
Okay, thank
Or
you.
it could be a whole another topic for a webinar, because it's a great question.
Yeah, so
Daniel,
I'll try to
last
summarize this, quickly. So the best available evidence, if you go to Google and type in triangle of evidence, you'll see a lot of images that pop up like a little triangle. And at the top of that triangle typically are systematic reviews and meta-analyses. And the next level below that are randomized controlled trials. Well, it's been beat in our heads as clinicians, et cetera, and as baby researchers, that randomized controlled trials are the penultimate evidence, right? Well, the triangle says a little differently. So any recommendations or guidelines that are based on systematic reviews and meta-analyses, which collate all the evidence related to a very specific question and synthesizes that is the best available evidence. A single randomized controlled trial in isolation is good information and can help change practice over time, but is not, in essence, the best available evidence if there are other studies out there on these issues. So if you come across something that's evidence-based practice or labeled somewhat differently, first investigate, is it linked to a systematic review and a meta-analysis? If it's not, then obviously use just a little bit of caution, because it's not based on a synthesis of the best available evidence, unless it actually references it as so. Yeah.
All right, well, we're at the hour, so we're going to end there. Thank you all so much for your time, and look forward to continuing these webinars and discussions. And please feel free to email me with any questions.